你搞回来了，
嗯，
怎么搞回来了你？
然后我在那搞，嗯，但是没事了，东西也苦啊，少，但是，嗯，
对呀，ဒီအဲဒီအဆင့် course ကဘာဖြစ်တာသူတို့ offline လုပ်နေကြတော့ဗီဒီယိုတွေပို့ထားတာဆိုဗီဒီယိုရအေးစိမ်မှကြည့်တော့မနေ့ကတစ်ချိန်ပြန်ရှိပါလေမနေ့ကတစ်ချိန်ပြန်ရှိပြီး24ရက်နေ့တစ်ခေါက်ပြန်ရှိတော့အဲ April 7ကျမှတစ်ခေါက်ဟုတ်တော့
我也没事了，
နောက်ဝဲလာနောက်ဆုံးကြရင်တော့ assessment နည်းနည်းပါရှိမှတင်တယ်
嗯
နည်းနည်းပါ
，OK，
ဆိုတော့လည်းဘယ်လိုပြောတယ်မလဲ Oxford ဆရာတွေသင်တာတော့ရှိတယ်ဒါပေမဲ့ခိတ်တော့လည်းနားလည်လာရောဖို့ပါလေကိုရ2 hours
我都来没了，ที่我
ဟုတ်တယ်
revision ဆက်လုပ်လိုက်မယ် anatomy
ဟုတ်တယ်
လောက်ပါပတ်တော့
အခုကဟောအဲ့ဒီပေါ်ပြတာနေတယ်အကုန်ပြီးသွားရင်တော့17ပေါ်ပါလေ
อืมပတ်တော့ဆက်လုပ်လိုက်
အဲ့
တော့43ပေါ့
อืมလုံးအောင်ရှိဒီနေ့အောင်ဘယ်လိုလဲအားရကြ
อืมဒီနေ့ကအားတယ်မနေ့ဖြန် OT ရှိတယ်တနေ့ကုန်ပဲညအထိတော့ညအထိတော့နေရမလားမသိ
ဒီ
ဘူးမနေ့က
ထိုင်စား
ကလေးကနေပြီးတော့တစ်ချိန်လုံးမတက်ရဲအာ
အာတော့ခွဲကြတာပဲ
ခွဲတာ4ခုပဲဒါပေမဲ့တစ်ခုကြာယူရင်အနည်းဆုံး3နာရီလောက်ကြာ
อืม
ဟိုဟာဌာန pancreas ဆိုတော့သူတို့လုပ်တဲ့ဟာတွေ
ဟော
နဲ့ခတ်တဲ့ဟာတွေများအဲ့လို
ဟော
weapon surgery တို့ဘာလို့လဲလုပ်တယ်ကြားတဲ့ဟာတွေအများကြီးပဲ pancreas
อื
cancer
ม
တွေလုပ်တယ်
ဟော
ပြီးတော့အဲ့ဒီ pancreas ကိုဖြတ်တီးဖြတ်လုပ်တဲ့ဟာတွေပြီးရင်
อืม
တစ်ခါကျရင် appendix လည်းလုပ်တယ် appendix ကတော့မြန်တယ်
อืม
မနှက်ဖြန်
အားဖြစ်တယ်
မနှက်ဖြန်တယောက်က syphilis ရှိရသူတယောက်လည်းပါတယ်
ဟော
ရှိရသူတယောက်ရဲ့
အာ
ပြီးရင်ဟိုဟာဗာလဲ PE ရှိရသူလေ pulmonary embolism ရှိ
ဒီ
ရသူ
အမောလို့ဆို
အဲ့ဒါကြီးကနည်းနည်းအနေရရှိရอืมအဲ့တော့ဘယ်လိုလုပ်ကြမလဲထိုင်ပါဒီ
အေ
က
း
ကြတော့
လက်ကနာလီကြောင့်ဖြစ်တာပြီးရှိ
ဟုတ်မှန်တယ်
อืมဒါရအာ
so ကြည့်လိုက်မယ်နော်
อืม
previously had the 46-year-old
အုပ် female
female guard
decide to
what's school non-tender right breast mass breast exam တွေရယ် weight loss fatigue rashes မရှိဘူး lipidation မရှိဘူး last mammogram from 2 years ago က negative တဲ့အာ
family history
history မ
ဒါ
ရှိဘူး
ovarian colon
medicine
cancer လည်း
ကောင်းတယ် physical exam က skin dimpling over the right breast when the patient is sitting upright with her arms
irregularly shaped,
Our lips.
adherent true centimeter by 3 centimeter,
Irregularly shaped.
about outer quadrant
Turn
of
to
the right
centimeter
breast.
by this number of paper.
2 centimeter is the limb of the sheet, no? Limb of the eye.
Outer quadrant, no? 2 cm is a lymph node.
Mm. Trauma and understand normal active power saw. Go need about see you know. Lush mats
What?
composed of
So desmoplastic stroma. Most likely diagnosis. Carcinoma inside the inflammatory breast carcinoma, invasive carcinoma, invasive lobular carcinoma, Paget disease. Paget disease လားမသိဘူးဟုတ်လား
Budget disease ကအဲ့လိုမျိုးတော့မဟုတ်ဘူးလားလေ Budget disease ကတော့ inflammation လိုမျိုးဟိုရောင်ကိုင်းနေတာလားအခု inflammatory blood carcinoma ဆိုတာလေရောင်ကိုင်းပြီးတော့လေဖောင်းတင်နေတာကြီး
อืม
ဟုတ်
အဲ့ဒါဆိုရင်
စာ
cardiac carcinoma inside တူလား
အဲ့ဒါကြီးလားမသိဘူးနော် lush granular cell with desmoplastic stroma သူ histology ကမေးဟာငါပြောရမ်းဖြစ်ရမှာ
အာဟာ
ကိုမဖြစ်တာမို့
อืม
invasive နဲ့ invasive dental နဲ့ DCIS ကတော့ common ဖြစ်မှာတယ်နော်ဒီနာ DCIS များလားမသိဘူးအာ
ရွေးကြည့်လိုက်မယ်invasive cardiac carcinoma တဲ့
mm
skin retraction template suspensory ligaments of Cooper
oh
superficial layer of superficial fascia, deep layer of superficial fascia, pain, skin retraction, fibrotic and shortened ligaments. Tumor, no? Breast carcinoma is the most commonly diagnosed malignancy in the United States for women. It's the second most common cause of cancer death in women. It is predominantly
specify
classified as
that
the or lobular.
reason for
That's lobular resembling
down at ish DDLU dominant lobular
lobular units HTTL finite lobular dominant and low view invasive carcinoma regularly shaped adherent breast mass about a quadrant is the most frequent site, and the axillary lymph nodes are the most common site of metastasis. The lymphatic eventually blowing cutaneous lymphatic flow. This can lead to a rush time body orange as erythematous plaques with prominent hair follicle resembling an orange pea. Malignant infiltration of the suspensory ligaments of the breast Cooper ligament can also result in skin dimpling. That progression shows signs of inflammatory breast carcinoma are associated with agreeable prognosis. Microscopic evaluation of the mass will show it typical that like glandular cells with desmoplastic stroma. Mammography is a screening method. Reading microcalcifications in breast tissue. Microcalcifications are present in many breast tumors and benign breast disorders. Fat necrosis, sclerosis, and adenosis.
microcalcification
The carcinoma is side 2 IDC ထိသွားနိုင်တယ်တဲ့ This is result from a malignant growth of epithelial cell that comprises the TTLU. This cell proliferates and feed the renal transmitted by interbasement membrane. There are many subtypes of this CIS. The minor histology findings, the combinatorial CIS show large pleomorphic cell where central areas and necrosis and dystrophic severe markers of clinical offense. Synthesis
Tubular carcinoma is side 2.
carcinoma red type. Lentiferous on the skin of the liver areola. It is underlying requested that the epithelial cell disease start up the lentiferous that into the nervous epidermis of the liver. This is classically present with an erythema, scaly rash of the liver areola. In particular, invasive the liver carcinoma, much less common than ITC. Area
Cellular expansion protein 8 cadherin.
it is
X-ray examination.
transfer of the carcinoma to the liver surface. Exudate over the liver. Large cell with a clear and observable histologically. ITC is the most common type of invasive breast carcinoma. The upper outer quadrant of the breast is the most common site. And the iliac lymph nodes are the most common site of metastasis. ITC typically presents as an irregular shape arterial breast mass.
All right, let's wrap up by talking about our invasive carcinomas of the breast. Remember, these are going to be cancers that break through the basement membrane and are really aggressive and malignant. So these are the ones that we really do not want to diagnose our patients with. Let's start by talking about invasive ductal carcinoma. This is going to be in the ductal region. And so this is going to be the progression of our ductal carcinoma in situ. This is going to be the most common type of invasive breast cancer. It's going to present as a hard mass with well-defined margins. This is going to be firm and fibrous tissue, and it's going to have desmoplastic stroma. Desmoplastic stroma is referring to the fact that fibrous tissue is trying to grow around this cancer and contain it. And so that is the response of the body to this really invasive cancer. And then these cancer cells are going to be described as small, glandular, and duct-like cells because this is going to be a cancer that is arising from the ductal tissue. Let's move on now to talk about our invasive lobular carcinoma. This is also going to be frequently bilateral, so this is going to be nasty disease as well. And like we talked about with our lobular carcinoma in situ, this is going to be all about cadherin expression. So here we have decreased E-cadherin expression, and this is going to lead to tissues that do not stick together well. So this is going to present itself as metastatic disease that is spreading away from its original location. And important here is going to be single file cells, which we are going to zoom in and look at here. And essentially these cells are going to line up in single file because they are now migrating. They've lost their cadherin expression. They are no longer sticking together. And so they're kind of marching out of their original location past the basement membrane and going on to metastasize. This is going to have a lack of duct formation because the ducts are essentially getting so deranged that these cells are spreading everywhere. And this is frequently without desmoplastic response. And remember, desmoplastic response is the body trying to create fibrous tissue to contain this cancer. And this is not happening because this is a really aggressive malignant disease process. So if we look here, let's do some compare and contrast. Our lobular carcinoma in situ is all contained nicely here within the basement membrane. However, with our invasive lobular carcinoma, we're going to start to get single file cells like these here, some more single file cells here. So these have lost their cadherin expression and they are just going on a march. They are marching to malignancy. That's how I like to remember this. And this is going to be a really, really poor prognostic sign. And this is the characteristic lack of desmoplastic.
Ừ. Chưa nhỉ? Nói ạ. Hello?
Response in this invasive disease process. Let's move on now to talking about medullary carcinoma. And this is going to be characterized by specific molecular things that you have to know with regard to this cancer. It's unlikely that you're going to get histological images, but you're going to have to know that these are large anaplastic cells in sheets and that they're going to be lymphocytes and plasma cells. So I want to highlight this in purple because I think of lymphocytes and plasma cells as really purple cells with like big nuclei. And so that's a way to really recognize this on test day. And it's going to be a well circumscribed lesion and it's going to be a mimic of fibroadenoma. However, the fact that this has the lymphocytes and the plasma cells, it's going to clue you into the fact that this is an aggressive disease type. Lastly, let's talk about our inflammatory carcinoma, which I'm going to highlight in orange, and you guys will see why in a second. This is a really, really terrible disease with a poor prognosis. Only 50% of patients survive past 5 years, and this is going to be a mimic of eczema and Paget's disease, so it's important to rule this out when you're working up patients. It's going to present as a painful, warm, swollen erythematous lesion or breast, and there's often no palpable mass here. So how are you going to recognize this? And the key physical exam finding is something called peau d'orange. And peau d'orange roughly translates to orange skin. And this is caused from hair follicles that are undergoing changes because of this cancer. And so this peau d'orange finding is what you see in the picture here in the chart. And it looks like the skin of an orange. And so if you were to see a picture of this on exam day, this is a big high yield red flag for our inflammatory carcinoma. And this is caused by invasion of dermal lymphatics. So we know that our dermis is going to be drained by lymphatics here. And so when those lymphatics are invaded by this cancer, it's causing like this little orange dimpling effect at the surface of the skin. And this is how you're going to nail this one on test day. So remember, guys, everything on this slide is going to be invasive malignant disease. And this is important to separate from our previous slides, which were non-invasive carcinomas or benign lesions altogether. I hope you guys enjoyed this video on breast cancer. Can't wait to see you guys in the next one. Bye.
Ừ. Ngại lắm.
Nốt cũ. Before T1B0
Crocodile and
that trimester.
tetromester, no?
Statistician for brain deficit.
Reports
Patient
occlusion.
breast and hip contractions and the baby moving
The
out.
baby moving.
Nice. Vagina disturbed and she leaks fluid when she sneezes or laughs, which is was over the past few weeks. By the side on a physical exam, probably female with the stress occurrence clear. No survivor. The
by Bisla crack. Adequate air movement throughout.
no edema and beta the cytoblast, the loss of amniotic fluid, miss urinary incontinence, overflow urinary incontinence, stress urinary. Oh, that's stressful, no? ခြေတာတို့ရည်တာတို့ဖြစ်မှာဖြစ်တာဟုတ်တယ်မလားဟုတ်လားမသိ
arch ညာ arch မှာအဲ့ဆိုရင် arch
stress မဟုတ်
ကျန်
လား
တဲ့က low arch ဆိုရယ်
stress ဟုတ်တယ်ဒါကြီးကဟိုအရင်တစ်ခါတော့လည်းဖြစ်သွားတယ်အဲ့လိုမျိုး involuntary urinary leakage stress urinary incontinence
involuntary urine leakage suggested
pregnancy မှာဖြစ်တဲ့ total body expand during the pregnancy blood and butter from maternal circulation can increase renal levels, increase sodium water retention, placenta societal plus can secrete human chronic ICG, stimulate the hormone release and the rise in GFR, prolong urine without a change. Fetus alongside maternal weight can increase intra-abdominal pressure. Pregnancy hormones can decrease urethral enhancing pelvic floor muscle relaxation. Pelvic floor muscle help support and position the blood and organ with horrible hyperrelaxation. Allows the urethra to move downward, resulting in a lower pressure in the urethra compared to the blood and urinary leakage. Urethral hypermobility can also greatly compress the bladder, further predisposing patients to increase urinary frequency.
floor embedded tristle control obstruction high post-bite procedure volume overflow ဟောဖြစ်တယ် post-bite procedure volume အများကြီးရှိတယ် incomplete emptying system voluntary dribbling diabetic neuropathy မှာရှိတတ်တယ် symptom during pregnancyကြည့်ရအောင်
Stalemate, sunshine hypertension, polylipidemia, lost down,
less specific
nice fever, chase, chest pain, shortness of breath, difficulty initiating urination and maintaining urine flow, bladder fullness, immediately avoiding tomo, no suprapubic or costovertebral degenerated is some repeats a smooth firm lengthened enlargement of the prostate. No abnormalities atypical glandulus and posterior prostatic lobe bacterial related inflammation, hypertrophy of the anterior prostate, nodular hyperplasia, stroma hyperplasia. Hypertrophy ဟုတ်လား
hyperplasia ပဲသူက hyperplasia ရတာပဲဖြစ်မှာ the lateral lobe တစ်ခုဖြစ်သွားတာမသိဘူးညလားသူ BBH ကို hyperplasia ပဲဆိုတော့လေ
ဒီလား
lateral lobe တွေများကြီးလာဒီလားလို့
ဟုတ်တယ် Nodular hyperplasia of the lateral prostatic lobes.
ဒီကညင်ပါပဲ
lower urinary tract symptom, urinary hesitancy frequency, and the setting of an enlarged prostate, benign prostatic hyperplasia. Deviation common and more than 50. Epithelial stroma hyperplasia predominantly transition zone directly surround the urethra as it enters the prostate gland. Prostate is an ovular gland encases the urethra and the vas deferens. It is located posterior to the bladder and anterior to the rectum. 3 zone center transition and peripheral is the most common site for prostate adenocarcinoma. Distal urethra only passes through a small portion of the peripheral zone. Thus, prostate adenocarcinoma does not typically cause urinary symptoms until advanced. Central zone surrounds the fully treated. Prostate can be divided into anterior, medial, lateral, posterior lobe, with BBH really occurring in the posterior anterior lobe. Prostate typically has a very rapid consistency on palpation, nodula, and film and PA. BBH portrays an stroma. Hyperplasia histologically atypical annular cells and MPA. As the prostate enlarges, progressive impingement of the prostatic urethra results in bladder obstruction. Overtime bladder may hypertrophy from the increased force needed to overcome this obstruction. This may further lead to dilation of the ureters, renal pelvis, and calyces nephrosis. Urinary reflux can predispose individuals to urinary tract infections, parenchymatrophy, scarring, and chronic kidney disease. Prostatitis bacteria in origin, E. coli, aroma, and Nasogonorrhea or Trachomatis, and sexually active.
question on the
As fever, chase, dysuria, urinary frequency, and exquisitely tender prostate-like gland on digitated ASM. PVH result from epithelial stroma hyperplasia, mainly affecting the transition zone, lower urinary tract symptom resistance, frequency and tripling physical exam, reviews and internal prostate with the frequency on palpation.
If we follow the vas deferens as it travels kind of around the bladder and then posterior to the bladder, we'll find that the vas deferens merges with the duct of the seminal vesicle, the first of the accessory glands that we're going to talk about now. The duct of the seminal vesicles and the vas deferens merges to form the ejaculatory duct. The ejaculatory duct then carries the secretions of the seminal vesicle together with what came through the vas deferens, the sperm, and then it takes it and dumps it right into the middle of the prostate gland, which consists of the prostatic urethra. So the ejaculatory duct travels and dumps the contents into the prostatic urethra, at which point the prostatic urethra is also receiving all of the secretions of the prostate gland. That's the other main gland that we're going to spend a lot of time talking about. Seminal vesicle and the prostate. After the prostatic urethra, we keep following the secretions. We'll see that the bulbourethral glands also contribute, and they release their contents into the prostatic urethra, as it really is now more so appropriately called the spongy urethra. And then the spongy urethra travels through the penis. We're going to talk about the seminal vesicle and the prostate, but you should know that the bulbourethral gland exists. And this is more anatomy, but it helps to give us some context for the glands that we're going to study now histologically. The seminal vesicle, the gland that is found, or the glands that make up the seminal vesicle, secrete a fluid that is rich in fructose and prostaglandins. Think of it like a nutrient-rich fluid that is going to help to feed the sperm within the semen. Now, that's what we're going to call that fluid that's produced. This is a low magnification image of the seminal vesicle. If we were to take a segment such as that little black box and we increased our magnification in there, what we would find is that the wall, the lining, the epithelial lining of the seminal vesicle consists of mucosal folds. This right here is a mucosal fold. So when you look at the seminal vesicle in low magnification, the lumen doesn't look nice and circular. It's kind of very irregular, and you see various cross sections through it. That's because the wall is folded, these mucosal folds. And lining, or actually making up that mucosa, is the pseudostratified columnar epithelium. And those cells are going to be the ones that actually secrete the fluid that becomes or contributes to the semen flowing through what will now be the ejaculatory ducts. So here we have the vas deferens. We have two of them merging with the duct of the seminal vesicles and becoming the ejaculatory ducts. The ejaculatory ducts are going to travel to dump their secretions in the prostatic urethra. This is going to be the prostate, and we're going to see that the prostatic urethra is right in the middle of it and will receive the secretions from the prostate. So let's look at that one next, the prostate gland. It's really not one gland, but rather it's many tiny little glands that are kind of organized into like 3 concentric layers. And all these tiny little glands are going to send eventually their ducts into the lumen of what is now the prostatic urethra. And here, the fluid that these cells are going to secrete is a fluid that is said to be alkaline. It's basic. It's not acidic. It's basic. It's got a high pH. And think about why this would be important. In the female reproductive system, we said that in the vagina, there was an acidic environment. And that was due to the glycogen being metabolized by the kind of normal flora bacteria that reside in the vagina. And so this alkaline fluid kind of helps to buffer that acidity of the vagina to keep the sperm alive so they can pass through without dying through the vagina. These cells are also going to secrete a prostate-specific antigen and prostatic acidic phosphatase. I only really mention these because if you ever have prostate cancer, these cells begin to secrete too much of their normal substances, such as, for example, PSA, and this would begin to build up in the blood abnormally. Some of it would diffuse and travel into the blood, and then you would find it, PSA, at abnormally high levels. It's one of the markers of prostatic cancer. The only reason I mention it's not really histological, though. Histologically, we take a low magnification image to look at some of these small glands in the prostate. What we'll find is that there are many of them, and it's hard to tell them apart. This is a hard histology. Hopefully, you're not going to have to identify these glands, especially the seminal vesicle. The prostate gland has a few things that maybe could help us to identify it. One, the epithelium that actually lines it is irregular. It's said to be, for the most part, simple columnar, but then it's got these patches of what look to be like stratified, pseudostratified, or simple cuboidal. It changes. So I don't really like to rely on that. I more so look at the stroma, so that's like the surrounding space deep to the epithelium. It's connective tissue, but it's got some muscle. The muscle is going to help to squeeze the content along during ejaculation. That's one good feature. My favorite is the prostatic concretions. We're going to do a little hard because they're our favorite. This is if the products produced by the prostate gland were to calcify in the lumen of the glands, then they form these concretions. Look for those to help you identify the prostate gland, right? So we've got this many different kind of folded epithelia with these prostatic concretions. That's how we distinguish the prostatic gland or the prostate gland. Functionally, there's one thing that I want to talk about, and it's the zones of the prostate. The glands are organized into 3 functionally important regions. There's one region known as the central zone, and it's all the glands that are kind of arranged around the ejaculatory ducts. So let's say this is going to be area number 1, the central zone. And then we have the transitional zone. These are other part of the many glands that make up the prostate, and they're going to around themselves, they're going to kind of organize themselves around the prostatic urethra. So let's call this zone number 2. And this is going to be clinically important because this zone, or the glands in this zone, are more vulnerable to becoming or to give rise to benign prostatic hyperplasia. If these cells start dividing, they're not cancerous, it's benign, but if they start becoming they're giving rise to hyperplasia, then there's more cells than you expect to have, and they begin to compress on, guess what? The prostatic urethra. And that would give the main kind of clinical symptom that you'd expect to find would be difficulty urinating, since it's squishing on that prostatic urethra. Lastly, surrounding this whole thing, so around the central zone and around the transitional zone, we have zone number 3. Let's call it the peripheral zone. And this zone makes up or occupies kind of the lateral parts, but also the posterior parts. And this is a zone that is vulnerable to prostatic cancer. This is a zone that gives rise to prostate cancer more commonly than the other zones. This zone is posterior, adjacent to the rectum, and hence would be palpable during digital kind of examinations of the rectum. Hence why that's the kind of routine test to see if prostate cancer is present in a male. All right, I'm going to give you this slide so you can look at it at your own time if you want to use it to help you review the glands in the different regions that are kind of histologically difficult to identify and usually will be tested in a more functional type of exam question rather than image-based identification.
သူစကားပြောတာတစ်မျိုးပဲနော်
နောက်တော့နည်းနည်းအပြည့်
ဒါ
ထောက်
လည်း
ထောက်
ဖြစ်တာလားမသိဘူးနော်သူ့ဗီဒီယိုကခုမှတွေ့ရကျန်တဲ့ဆရာတွေပဲများတယ်ပြီးရင်တော့ခု
အသက်ပဲရှိသေးပါလား pediatric Australia history
Show
What about
you know swelling in her extremities and
I got a neck mal as well yeah
neck what and dirty diapers
fit on ဖြစ်တယ်
say
what is high blood what is it
yeah let's say sharpness
a lot neonate no stress pupa equal round reality line plus plus က normal လားလို့ဘာလို့ခါကြအဲ့လို plus မှာချက်
swelling is
some localized symptom over the history and
is that
regular rhythm without pathology had saw lens clear abdomen and tender swelling appreciated over the and feet with the obvious structural abnormality based on the find
voilà အတောင်းလား
down တော့မတူ down ဆိုရင်တော့အဝါရရှိရမှာ facial features တွေပြမှာနော် down လည်းမတူဘူးလား hypothyroid ဆိုရင် hypothyroid feature တော့မတွေ့ဘူး blood ဖြစ်နေတယ်တဲ့ hypothyroid ဆိုပျော့ခုပျော့ပြီးဖြစ်နေအောင် hypotonia ရနေရမှာပေါ့နော် hypotonia လည်းရှိမနေဘူးအထွတ်နဲ့ပတ်တူးတွေကတစ်ခုပဲအဲ့ဒါအဲ့လိုပဲဘာမှမသိဘူး
Turner syndrome
အားကြီးလားဘာလို့ဒါနာဖြစ်ရအောင်
မျိုးသမီးမလား
sister hypo
အင်း
yeah sister hygroma ဘာဖြစ်တာ web တော့ကြားဘူးလေကွာ
posterior neck mass ကားရနော်
that new features လည်းရေးမထားဘူး
Roma bilateral extremity swelling lymphedema Turner syndrome.
Finding Turner syndrome, genetic paternal
Normal lymphatic.
normal lymphatic shall lead to dysphagia, respiratory stress, serious infection, neuropathy, surgical intervention, swelling, decrease with age.
In the posterior neck region, dysphagia, respiratory distress, and serious infection may require surgical intervention. Swelling decreases with age.
Shall be center, but can progress to more severe manifestation if not untreated. Shall be present with mice or hypothyroid, hyporeflexia, hypothyroid, hyporeflexia, hypotonia, lethargy, everywhere power movement. Acrocolloid shard, nationally posterior frontal down and do not now. You are around a bed to a palm of the lady. I don't know, chromosome 18 months.
Trisomy 18, second most common trisomy in live births in US.
That was for 18. Not terrible.
Rocker
Trisomy, Tom,
severe
Roman or support, rocker bottom feet, severe ID. Clench fist with overlapping finger, load set, yeah.
congenital heart disease.
Congenital heart disease.
GI.
Margata vertical. Anomaly of the polypedalane buffalo mesenteric ventline duct. Thing about the precorder misota at the
Female, partially or completely missing, and is chromosome lymphedema. The extremity is present at birth. With age, cysticercoma, congenital lymphatic defect. Biology GBY nalo.
Welcome, baby learners. In this video, we're going to be talking about the reproductive system, specifically looking at how male and female development are different and how they're the same. Let's jump in. So let's take a look and review at what happens in some of the first moments of fetal development. In early fetal development, the gametes of the embryo are already being formed. They're going to migrate from the yolk sac into the abdominal cavity, into something known as the genital ridge. These bilateral ridges sit right next to the mesonephros and the mesonephric ducts. Those were really important in the formation of the urinary system, but also become important here. So basically, these primordial germ cells, these gametes that are being formed, are going to start to become surrounded by somatic support cells, which we've abbreviated as SSC. Together, they create these things known as primitive sex cords, which sit in the abdominal cavity. These two cell groups are mutually dependent on each other, so it's really important that we know that they stick together. We'll see why in a sec. Next to the development of the genital ridge and the mesonephros, we see another bilateral structure appearing. These are the paramesonephric or Müllerian ducts. For the record, I will be referring to them by both names. They extend from the region of T3 all the way to the urogenital sinus, but before they actually insert to the urogenital sinus, they fuse. This duct system is going to become really important in females as it becomes the uterus and the fallopian tubes. But first, we're going to jump into male development. This begins with the expression of the SRY gene found in the Y chromosome. This becomes immediately important in those somatic support cells that we just talked about. The SRY gene is what's responsible for biological sex as well as primary sex differentiation. When those somatic support cells express SRY, they start to turn into Sertoli cells, drawn here with an S. These Sertoli cells go on to do many things, which we will examine. The first thing that they're going to do is encapsulate the primordial germ cells with the help of local mesoderm, creating folds called testes cords. These cords will then turn into seminiferous tubules. Remember, there are all those structures that connect the seminiferous tubules to the actual vas deferens. Sertoli cells are responsible for differentiating into the rete testis. Those are going to be what are responsible for connecting the seminiferous tubules to the epididymis. But between that connection are those mesonephric tubules we left behind. Those become the efferent tubules. Additionally, Sertoli cells are going to release an important hormone, anti-Müllerian hormone, which is the hormone that indirectly causes the paramesonephric or the Müllerian ducts to regress, hence why males don't have a uterus. Beyond that, they also secrete a signal that transforms mesonephric cells into Leydig cells. Leydig cells are going to become really important in a minute, but let's recap what we've seen so far. Our Sertoli cells themselves went on to create seminiferous tubules, but they help signal everything else. Cells from the mesonephric tubules became efferent ductules, and the mesonephric duct will turn into the epididymis, vas deferentia, and the seminal vesicles. But how? All of this is dependent on intricate hormone signaling. So those Leydig cells that we just mentioned are going to produce two really important things here. The first is testosterone. Testosterone is what's going to maintain the mesonephric duct and to form the seminal vesicles, the vas deferentia, and the epididymis. But the Leydig cells also secrete 5-alpha reductase, which is an enzyme that converts testosterone into dihydrotestosterone. Dihydrotestosterone becomes really important in male reproductive development. It's responsible for developing things like the urethra, the prostate gland, the penis, and the scrotum. And it plays an important role in developing external male genitalia, as we'll cover in a second. But first, we gotta look at testicular descent. So the testes actually start higher in the abdominal cavity than they end up, somewhere around T10. They're held in place by the cranial suspensory ligament that attaches them to the diaphragm, and the gubernaculum attaches it caudally to the abdominal wall. So that cranial suspensory ligament is going to slowly degenerate, and thus the more stable gubernaculum pulls the testes caudally. As it does so, the shape of the peritoneal cavity is also changing. It ends up enclosing a pocket of the peritoneal cavity just between the penis and the scrotum. That's called the vaginal process. The vaginal process is supposed to completely obliterate. It'll condense into two layers, the parietal and the visceral, of the tunica vaginalis. But there are cases where that vaginal process doesn't properly disappear. In those cases, we see a few problems. Fluid can collect in that little pocket, forming something known as a hydrocele. It's pretty common, it can self-correct, but it's dangerous if it doesn't. In more serious cases, parts of the intestines can get trapped into that vaginal process, causing an inguinal hernia. Fortunately, these symptoms aren't life-threatening and treatments are available. So, on to external genitalia. Just to recap where we are. Here's a sagittal view of the urogenital area. We have our urogenital sinus and the anus. Above that area is something known as the genital tubercle. In males, all external genitalia is dependent on the expression of dihydrotestosterone. Remember, that came from Leydig cells. So what's going to happen is the presence of that hormone or not is what's going to determine the external structures of either sex. So the genital tubercle in males is going to elongate into a penis. The area directly surrounding the urogenital sinus are known as genital folds. In males, those fuse at the midline and basically disappear, enclosing the urethra in males. Just next to the genital folds are the genital swellings, which will contribute to the scrotum. So as you can imagine, in females, this progresses entirely differently. It progresses without the presence of dihydrotestosterone, making it kind of a default. The genital tubercle is going to instead form the clitoris, while the genital folds somewhat disappeared in the male. In the female, they become the labia minora, and the genital swellings surrounding that go on to...
iPad နဲ့ဝင်လိုက်
အကောင့်နှစ်ကောင့်ဟုတ်လား
ဟိုဖြစ်တာဖုန်းနဲ့ iPad နဲ့ဝင်တယ်
Form the labia majora. So from here, we're going to go into female development. So it all starts the same way in females that it did in males. When primordial germ cells migrated from the yolk sac into the genital ridge. Somatic support cells surrounded them to form primitive sex cords, but because there was no SRY gene expression, they develop into follicle cells instead of Sertoli cells. So what does that mean for genital development? First, those follicle cells, in tandem with local mesoderm, are going to start to form ovaries. Due to the absence of testosterone from Sertoli cells that appear in males, those mesonephric tubules and ducts are going to regress. There's also no anti-Müllerian hormone present, so the paramesonephric ducts, the Müllerian ducts, are just going to remain there. As I mentioned earlier, those become the fallopian tubes as well as the uterus, which ultimately is going to insert into the urogenital sinus. So as you can see in our little embryo drawing, now we have ovaries, uterine tubes, uterus, all of which are inserting into the urogenital sinus, which ultimately that opening is going to split into the vagina and to the urethral orifice in external development. Now, a couple things can happen here. In the case that the Müllerian ducts don't fuse properly, we can observe a couple different situations. Here are a few. All of these are going to increase rates of menstrual cramping and pain, difficulty getting pregnant, preterm birth, child in a breech position, miscarriage, etc. It's a little complicated. The first is didelphic uterus. This is where both Müllerian ducts developed independently or merged late, causing a double uterus and a double vagina, and sometimes a double cervix too. Then there's a case where there's a unicornate uterus. This is where one of the Müllerian ducts fails to properly develop. It leaves a uterus with only one fallopian tube. Sometimes the remainder of the other duct appears as something known as a hemiuterus. That can cause a lot of problems and pain when it comes to menstruation. And then the last one we're going to cover is septated uterus. This is where a septum divides the uterus, and in some cases, it can divide the cervix and the vagina too. So beyond issues with proper uterus development, there are some genetic conditions that can cause abnormalities as well. The first we're going to look at is Turner syndrome. In this condition, a female is born either without or an incomplete second X chromosome. This kind of monosomy causes primordial germ cells and their somatic support cells to die. Now, there's no Y chromosome, so there's no male phenotype here. But this female does present with some signs like a short stature, a webbed neck, eyes that are tilted with a wide nasal prominence, sometimes swelled hands or feet, and other internal complications. This is not highly treatable beyond hormone therapies for height delay or for proper maturation. The next clinical correlate we're going to look at is persistent Müllerian duct syndrome. In this situation, which is extremely rare, an XY male presents with female anatomy. In this case, the gene that codes for anti-Müllerian hormone or its receptor is genetically dysfunctional. As we mentioned before, anti-Müllerian hormone is the hormone that causes the regression of the Müllerian duct in males. In the case that we don't have that hormone, the Müllerian duct is going to persist. So a male with an external and internal XY male phenotype also contains a uterus and fallopian tubes. This can cause a lot of internal complications, one of which is cryptorchidism. That's where the testes fail to properly descend. It can also cause things like inguinal hernias or an increased risk of infertility or testicular cancer. Long story short is that the female structures need to be removed in order to prevent further complications and to correct the position of the testes if undescended. So let's jump into a review question and see what we've learned so far. The secretion of blank is what causes the paramesonephric ducts to degenerate in males. A, 5-alpha reductase, B, dihydrotestosterone, C, anti-Müllerian hormone, or D, testosterone. Take a minute to think about it. We're going to go over it right now. So A, 5-alpha reductase, not the answer. 5-alpha reductase is what converts testosterone to dihydrotestosterone, which leads to things like proper male internal and external development. It doesn't have anything to do with the paramesonephric ducts. Neither does dihydrotestosterone or testosterone. So that leaves us with C, anti-Müllerian hormone. The Müllerian ducts degenerate when anti-Müllerian hormone is present. So I hope this video was helpful in understanding more about reproductive development. We'll see you here next time. Welcome, baby learners. And
Sao có cả tam bị thả là New thả là Hello. Chà.
Chà, chà.
Oh, chà.
Ôi, bố biết chuyện đó à?
View hả?
Biết chuyện đó à? Ôi, biết chuyện đó mà đi là chứ? Nào, chưa rồi. Biết chuyện đó mà đi, chưa có con này phiêu nè.
Hola. Mình đi và sao mà xí đầu lại được cả. Kìa.
Chưa có con này giờ xuất sốc đi. Tao cũng chi biểu. Bảo rồi, tôi đã nào vậy bạn? No.
Mình chia ra thì cái nào này nào. Tôi move from did not receive food America. Okay. By the sign being short stitch.
Cái thành công này quá.
No.
Short stitch no Australia airline. Short thick neck. The wide angulation of the arm stay. Stacks to stand her arms to our sides and fully extended. Both one's angle with my body. So, no? No better rashes. Hypergonadotropic. Hypogonadism.
Every subject fellow bicuspid above mitral above polar ocular hypertension. Stenosis of cervical vertebrae. အဲ့ဒါကြီးမလား E လား
ကျွန်တော်တို့ထင်တယ် B လို့ထင်တယ်
ဟမ်
bicuspid department များ
ဟုတ်လား
လောကပြည်ပါတင်တာဒီပါ
E လားလို့လေ
B လားဟုတ်လား
Stenosis of cervical
ကျွေး
vertebrae
ကြည့်ပေါ့နော်ဟုတ်ကဲ့ကျွန်တော်ကြည့်တယ် B
အော်
လို့ထင်
B ရမယ် bicuspid
bicuspid department coordination aorta bicuspid department အရင်က common ဖြစ်တယ်
ဟုတ်တယ်မသိဘူး level ဖြစ်လို့ဟိုအိုင်လာလို့ cervical လား
နင်းဒီမှာရှိတယ်နောက်က streak ovary နဲ့လေ streak ovary နဲ့ ovary တူလေးပဲအဲ့ဒါတော့ offensive LH ကထောင်တက်ပြီးတော့ estrogen testosterone လည်းပဲပြုတ်ကြ
Large palate short stitch low set ear low posterior halo
Australian web neck
hygroma cystic hygroma ဆိုတာဒီတိုင်း she chest widely spaced nipples short foot metacarpals osteoporosis lymphedema
တပြားစာ gonadotropoma ဖြစ်လာတယ်
variant dysgenesis infertility streak ovary primary amenorrhea delayed puberty gonadoblastic advice what is sorry what's you can type to the tension coordination bicuspid of
horseshoe condition ဟုတ်တယ်
vitus buccal non-discharge
Cubus focus
decreased level and being testosterone estrogen early conversation bicuspid above to the leafless use during early development resulting
early diastole hypoglycemic
instead of the number 3 leaf above
story, aortic
cyclic heart over the
regurgitation,
Okay.
Stage.
As the above classifies, it may result in progressive valvular dysfunction manifesting early illness or aortic regurgitation. Bicuspid above is associated with various vascular conditions, including thoracic aortic aneurysm, aortic dissection, condition of the aorta, common finding in Turner syndrome, and infective endocarditis. Choice A, idiopathic separated Down syndrome, choice B, mitral valve. Choice C, mitral valve, congenital prolapse.
Prolapse ကဘာမှဖြစ်တာများတယ်နော်သူက Dana လို့ပါတော့ Dana လို့ muffin မှာဖြစ်တာAladdin loss
Giant syndrome
collagen 5
Alas, down loss. Noonan syndrome. Choice D. Ocular hypertelorism. Klippel syndrome. Survived by the perfusion.
Bro, ခုနဟာပဲနော် Aunt female got to pediatrician by an annual physical examination. Reports patients been doing well with peace studying kindergarten in the fall. She can go to 10 thick times, follow similar direction. She chest pain, abdominal pain, weakness, leg pain, shoe, at a sign gone.
What not? Down
River shot 1 to 280. Left mark, dear. 6ကြာနော်164 20လောက်กว่าနေတော့ Pitted female with web nut in no acute distress. Pupil equal.
Ema.
No? The order is much smaller.
Tanawe. Trusted approaches what Naxis Theogroma. Evangioma.
Got to show you the pre and post data. Pre and post data. Got to show you the what diploma for troubles that are users responsible. Big absent femoral bust
says that it is materials just supply that lower extremities. The upper extremities will have and blood pressure compared to the lower extremities from decreased blood flow. Discrepancy in blood pressure activate the RA system, elevating the upper extremity.
Life concern moments in the United States. The Dutch users normally close fire boats functional closure. 18 to 24 hours after birth and not crucial several days to begin malignant arteries pretty tube shiny. Okay. ပြီးတော့ကြည့်သွားလားမြည်လားကြည့်သွားရင်နော်
33 minute. No significant.
33 week no significant plasma strip lump on his right testicle. Notice irregularity when performing some exam in the shower. Complain of feeling shaky, having palpitation in the past week. Fever, chill, weight loss, chest pain, shortness of breath, abdominal pain, constipation, testicular pain, penile discharge or rash palm shoe. By sign, gone. This guy examined diaphoretic tremulous may in acute distress. His pupils call round ready to lie. Then damage is noted over the right testicle, close the discoloration of swollen shoe, testicular ultrasound. What pipe him? Yeah, I appeal loud.
I'm up here, you are. Voila. Testicular tumor, lymphoma.
Oh, lymphoma is a limb of the G.
Oh, that's a tumor. Satoli
What you want him?
lady cella and the great word. Satoli cella.
I'm to shaky, really shaky and having palpitation with the past several weeks. These are Peter ACG 20. Peter ACG are stimulating hormone and cussens. Through the county, oh, yeah, oh, switch charging to them. No. Do Peter ACG 20 tumor.
Also jam cell.
Big on trouble. Jam cell tumor. Some new one. Now, it was jam cell tumor. Some new one, no?
Testicular tumors. Jam cell tumor, 95%. Seminomas, non-seminomas, Brana, carcinoma, teratomas, carcinoma, sarcoma, misjam sarcoma.
Jam cell 95%, no?
Sarcoma.
Seminoma,
Satoli cell. Secondary testicular tumor, lymphoma, leukemia. Metastatic prostate, lung, skin, kidney. Hypothyroidism, planitia, hypertension, palpitations, apheresis, trauma, tachycardia, painless, solid, testicular mass, testicular tumor.
solid.
Do
not trans-eliminate. Trans-elimination does negative, no?
Horizon, yeah, man. Each sunlight of the
Yeah, man.
Reportant testicular gems, tumor. Seminomatous, non-seminomatous. Carcinoma, teratoma, miss.
Carcinoma, teratoma, mix. Respect out the Rama Jam Tumor. Beta subunit of the beta ACG is unique to ACG. FSH unit is shared among several hormones, including FSH, LH, TSH နဲ့တူတယ်နော်ဒါ TSH နဲ့တူတော့ thyroid ကိုသွားပြီးတော့ stimulate လုပ်တော့ thyroid hormone တွေထွက်တာများလာပေါ့နော် TSH receptors in thyroid follicular cell leading to increase the thyroid hormone production hyperthyroids. Ladies cell tumor က non-germ cell tumor androgen estrogen ထုတ်တယ် ladies cells ဆိုရင်ဘာဖြစ်လဲ gynecologist sexual precocity Frankie sister hypereosinophilus cytoplasmic inclusion Satolia or benign tumor. Estrogen is typically testicular lymphoma, the most common testicular tumor in older women, Chelsea tumor, no? Most common form is rounded diffuse large B-cell lymphoma. Secondary involvement of the testing. CGA time of alpha and beta section alpha and they get to form essential stimulating hormone.
All right, guys, let's continue our discussion on testicular cancer by talking about our germ cell tumors. I'm going to put this little purple squiggly next to our germ cell tumors to remind you guys that 95% of all of our testicular cancers are going to arise from our germ cell tumors. You'll remember in our video on testicular cancer, we talked about our 95% arising from our sperm cell progenitors, which was this purple population of cells that we talked about that are different from the stromal cells, which were our Sertoli and our Leydig cells, which we denoted in orange over here. So now that we're kind of oriented to the cell type that we're talking about, let's get into this table where we're going to talk about the specific things you need to know about each of our type of germ cell tumors. We're going to start out by talking about the epidemiology and presentation of each tumor type, and then we're going to move on to talk about some of the lab values that you might expect and some of the histological findings of each of these tumor types. So let's start off by talking about our seminomas. And seminomas are going to be the most common type of testicular tumor. They present as a homogeneous testicular enlargement, and this is going to be a painless tumor type. So in a vignette, this would be a patient that notices a painless lump on their testicle. This should not be painful. And then in terms of the prognosis here, these are going to be malignant tumors. However, they take a while to metastasize. So there is some time that you have to diagnose this before it goes on to full metastasis, which means that they have a really good prognosis. Like I said, this is going to be the most common testicular tumor. And then important here is that this type of tumor does not affect infants. So you will only expect to see this tumor type in aged toddlers and above. No babies here. So talking about the tumor characteristics, and it's important to know that this is the male analog of ovarian dysgerminoma. And remember when we talked about ovarian dysgerminoma, we talked about the classic fried egg cells, and these are described as a vacuolated watery cytoplasm with a central nucleus. And so this is going to be a large cell in a lobule of watery cytoplasm, classically described as fried egg cell. So let's take a closer look at this fried egg cell so we can get a better idea for test day. I'm going to outline a classic one here so you can notice what I'm outlining is a cell that has this white watery cytoplasm. This is like the egg white, and then that purple nucleus in the center is like the yolk, and this looks to me like a fried egg in a pan, and that's a great way to recognize this on test day. In addition to the fried egg cells, we can expect to see increased placental ALP, and it's notable that this is a radiosensitive tumor. So in addition to radical orchiectomy, if this tumor had metastasized at all, the metastasized tumor is going to respond really well to radiation. So that's really great, especially because this is a tumor with a really good prognosis. Now, let's move on to our next tumor, which doesn't have such a great prognosis. And this is like what I think of as the meanest testicular tumor. This is going to be our embryonal carcinoma. And the reason why I think of this as a mean tumor is because it is painful, it is hemorrhagic, and it's associated with necrosis and a poor prognosis. So painful mass, hemorrhage, necrosis, and then these are malignant, and as opposed to seminoma, they're going to metastasize very early. So they have a poorer prognosis compared to our seminomas. Additionally, these can be mixed with other tumor types. So that's an additional aspect of this tumor that's important to know. And you can differentiate a pure versus a mixed tumor based on other lab values, which we'll talk about in a second. So when we talk about the tumor characteristics, it's going to have glandular and papillary characteristics on histology. So let's take a closer look at this histology and what we're looking for. And I want to actually compare this to seminoma because they are so different. You'll remember in seminoma, the tissue was very uniform. It was all these fried egg cells just kind of lined up nicely. Whereas you'll notice that in our embryonal carcinoma, we have this like hemorrhagic necrosis occurring here. And this is associated with nucleus that are overlapping. So you can appreciate that these nuclei are all overlapping on top of each other. We have these associated red blood cells, which represent the hemorrhagic necrosis. And then another finding you're going to see here is clusters of cells surrounded by white space on three sides, like this example here. And it's important to differentiate this from seminoma, which also has a lot of white cytoplasm around it. But you'll note that in seminomas, we only have one nucleus surrounded by white cytoplasm, whereas in the embryonal carcinoma here, we have like 3, 4, or 5 nucleoli all within this white cytoplasm, and you're going to have all this disorganized hemorrhagic necrotic tissue, and that's how you're going to differentiate this really aggressive, mean, malignant, bloody, painful tumor from the more benign, non-painful seminoma that has a good prognosis. So let's move on now to talk about our teratomas. These are also an analog that we talked about in the female pathology unit. So let's go ahead and talk about it in the male. So in our female patients, these were always benign tumors, whereas in the male population, these can actually be malignant in our adult male patients. So differential presentation with age and sex. In our adult males, these can be malignant or benign. So I'm going to note that they're malignant here in the adult male as a possibility, whereas in our pediatric males, these are always going to be benign, and in all of our females, these are going to be benign. So basically for teratomas, if you have an adult male, you want to have a higher suspicion that this could be malignant. Now, in terms of the description of the tumor itself, this is going to be very similar to the female analog. It's going to be a cystic mass. And important here is to note that there's all 3 germ layers. So I'm going to highlight the 3 in red because that's really important. We're expecting a heterogeneous mass composed of ectoderm, mesoderm, and endoderm. So all 3 embryological germ layers. And another way that they may hint at this on test day is by describing a lot of different tissue types. So they might say that it's composed of hair, teeth, and sebaceous tissue, a mixture of different tissue types. This is key to the teratoma. And you can also appreciate this on gross exam. If we zoom in a little closer here, you'll notice that this teratoma has distinct regions of tissue. So here in the periphery, we kind of have this darker tissue type, and then we have this really nodular tissue type up here. And then we have a more uniform tissue type down here towards the base. This is representing all the tissue layers in harmony within this teratoma. Let's move on now to talk about our yolk sac tumors, which are also known as an endodermal sinus tumor. And this is going to be the most common tumor in our children below 3 years of age. So as opposed to our seminomas, which spared our infantile population, our yolk sac tumors can actually affect the much younger kids. And this is going to be a malignant and aggressive tumor, and it's the male analog of the yolk sac tumor that we saw in our females. On a gross exam, this will be described as a yellow and mucinous tumor after radical orchiectomy. And then on histology, we expect to see what are called primitive glomeruli, also known as Schiller-Duval bodies. So let's take a closer look at what a Schiller-Duval body is, because I always had trouble recognizing this as a medical student. And it's important to note that you're going to look for like this central shard-like eosinophilic inclusion surrounded by cells with a lot of purple nuclei. So you can appreciate a great example here. Here's this like really discrete eosinophilic shard. This represents the blood flow of the primitive glomeruli. And then you have these purple cells all surrounding it kind of in a circular pattern. That's how I recognize this one on test day. And then additionally, in terms of lab values, you can expect to see increased AFP on this tumor type. Finally, let's wrap up by talking about choriocarcinoma, which is going to be a malignant tumor with hematogenous spread, which means that it can easily spread through the bloodstream. And we talked about this a little bit in our talk on molar pregnancies, because this is a complication of molar pregnancies. However, this can also arise as a testicular tumor from the germ cells of the sperm. And so what happens here is we get metastasis to the lungs and the brain, and these are classically described as cannonball metastases. So there's these big ball-like metastases that you can see on X-ray in the lung or on head CT in the brain. And then these can be associated with gynecomastia and hyperthyroidism, and this is due to the fact that these tumors just pump out a ton of HCG, which causes these hyperthyroid type effects. And if we were to look at the cellular histology here, we would expect to see disordered trophoblastic tissue. And we know that trophoblast is made up of both syncytia trophoblasts and cytotrophoblasts. So I'm going to underline the syncytia trophoblastic tissue in purple and then our cytotrophoblastic tissue in orange. And normally during development of the trophoblast, these two tissue populations are distinct, so they're separate layers. However, you will notice that in this tumor type, we have disorganization of these two structures. So in our cytotrophoblast, which is in orange, we have it kind of lacing through this lighter tissue here. It's all the light eosinophilic tissue, whereas our syncytia trophoblast is this darker purple tissue. And you will also note that it kind of laces through disorganized. We literally have cytotrophoblastic tissue inside of syncytia trophoblastic tissue. This is no organization whatsoever. Normally, there should be two distinct layers, and this is a great way to denote this type of tumor on histology. So if we were to also look at our lab values here, we would notice that this is an increased HCG lab value. This is going to be severely increased because just like in molar pregnancies, this tissue type is just pumping HCG. And this is going to be a great way to clinch this type of testicular tumor on exam day. So to review, it's important to know the different types of testicular tumors that arise from germ cells. Remember, these are 95% of all testicular tumors. You need to know the histological findings of each of these as well as the lab values associated with them. We're going to talk about the last 5% of our testicular tumors in the next video. Can't wait to see you guys there. Bye.
Bye.
Yeah.
Oh, not cool. Don't get shown. Female. So she husband has been included in the course of the past year with a positive pregnancy test. As per research similarizes reveal no abnormalities. She denies fever chase, weight loss, chain, but that she's mentioned as suppressed, abdominal pain, China pain, or discharge. At the same time, days are the female with no distress multiple condoms expressed around her jawline or shoulder. အဲ့ဒါ testosterone တွေများလို့ထွက်တာပေါ့ဝက်ချန်တွေထွက်တာလေနော်ဟုတ်လား testosterone ဝက်အောင်များတယ်မသိတယ်ပေါ့နော် no survivor or Israeli retinopathy dominant and dystonia my bilateral arrangement with our spiker with the discharge and is a masturbated during my manual exam. Systemic now ovarian mass for large papillary projection. ဟိုဘာဖြစ်မလဲညာကိုထနာဖြစ်မယ်ညာဖြစ်လားဟမ်ဒီကဆယ်
Because I'm the
ကိုလည်း late Saturdays ချင်ပါလေ Saturdays ပြီးတော့မရှိရနော်
this Gemini also jam say chuma
testosterone တွေထွက်နေတယ်ဟာညော့နေ
ဟုတ်လားအဲ့ဒါဆို sexual related
cellulite ဆိုတာရှိလားမရှိဘူး
မရှိဘူးလေနော်ကိုရေးကြည့်လိုက်ဒီရေးလိုက်မယ်
အဲ့ဒါ satellite အဲ့ဒါပဲယူလိုက် satellite
နောက်ကျပါဟဲ့လက်က sexual related ဆဲကျူမ
ဟုတ်လားဘာလို့လဲ satellite ဆိုတာဘလူးအိုဒီမှာရောက်လာနားမလဲ or small subconstrument tumor that primarily produce testosterone
လောင်းမယ် secondary follicle tertiary follicle primary follicle ဒီတလေးဆဲကျူမ
ဟောရှိတယ် subconstrument tumor cellulite cell tumor တော့ရှိတယ်ဟုတ်တယ်ခါမှမကြောက်ဘူး
Germ cell tumor sescostroma tumor 3 to 5% of all ovarian tumors granulosa cell tumor Diga cell tumor ovarian fibroma circulated cell tumor germ cell teratoma disseminoma and gestational glioma Bronchial tumor
biliary tumor နော် subconstrument tumor
cell tumor ovarian circulated cell tumor small sescostroma produce testosterone Things such as review testiculated popular projections
realization secondary ending hospital nitrogen alopecia saturated cell tumor where most of the events between 30 and 40 years so
particularly present with signs of fertilization fertility
testicular cell true နော် it's probably germ cell tumor oocyte dry such cell tumor ဒီကူမာလို့ခေါ်နော်တကူမာ That's the program stromal tumor most commonly occurs when it was at release Shiratival bodies Yoxite tumors Shiratival bodies and Yoxite tumors
All right, guys, let's wrap up our discussion on testicular cancer by talking about our non-germ cell cancers. I'm going to put this little orange squiggly here and denote that non-germ cell cancers account for 5% of our testicular cancers. And I want to orient you guys to what this means. Remember, in our testicular overview video, we were talking about that 95% come from this purple population of cells, which was our sperm progenitors, and then 5% of our cancers are going to come from our Leydig and Sertoli cells. Our Leydig and Sertoli cells, we denoted as these orange cells. It was our Sertoli cells that were here nurturing the sperm, and our Leydig cells out here on the periphery that were creating testosterone. So I just wanted to reorient you guys that in this video, we're going to be talking about this orange population of cells, which only accounts for 5% of all testicular tumors. So if we want to go ahead and get started by talking about this, let's start off by talking about our Leydig cell tumor. And Leydig cell tumor is really important to know because it looks very similar to yolk sac tumor, which is a germ cell tumor, which we talked about in the previous video. So I want you guys to be carefully comparing and contrasting the two as we go through this. So in terms of our Leydig cell tumors, they're benign, and they're going to present with precocious puberty or some sort of sign of excess androgens or excess estrogen. And this is because they produce either excess androgens or excess estrogens. And this can present as gynecomastia or precocious puberty or some other sign of excess hormone that's being produced by this tissue. And this makes sense. We know that Leydig cells are responsible for making hormones. And so if you have a cancer that's full of hormone producing cells, you're going to expect some type of hormonal aberration. So like I said, these are going to produce androgens or estrogens. And then on gross exam, these are going to be described as golden brown. And I want to note that this is very similar to how yolk sac tumors are described. Yolk sac tumors are described as yellow and mucinous. And I think that yellow and golden brown sound very similar. So it's important to be able to make that discrete distinction between the two. Additionally, both of these tumor types have eosinophilic inclusions or eosinophilic shards within them. And I want to talk about the key differences between these two. So in our Leydig cell tumors, it's important to note here that this is an intracytoplasmic eosinophilic inclusion that is shard-like. So you'll notice that this pink eosinophilic shard is within the cytoplasm. It's within the entirety of the cell. So you can see the cell is outlining this shard here. Whereas if we look over here on the side, we're going to see this is an example of red blood cells flowing through a capillary, which can look very similar. They're both this really intense hypereosinophilic inclusion. However, you'll notice that these red blood cells are actually flowing through a vessel as opposed to being intracytoplasmic. And this is important to differentiate from our yolk sac tumor, which has Schiller-Duval bodies. And the Schiller-Duval bodies are primitive glomeruli, and they have blood flow flowing through the middle of them. And so the Schiller-Duval bodies are going to look much more similar to this because it's blood flowing through cells. Whereas in our Ranke crystals for this tumor type, we are looking at an intracytoplasmic inclusion. And I cannot stress enough how similar these can look and how it's important to be able to differentiate them. So like I said, Ranke crystal is going to be something that we see in our Leydig cell tumors. Let's move on now to talk about our Sertoli cell tumors. These are also called androblastoma, and these are going to be benign tumors because they are just tumors of the cells that support developing sperm. So they're not going to be producing large amount of hormones. You're not going to expect hormonal change like we expect in the Leydig cell tumors. And these are going to be composed of sex cord stromal tissue. And in terms of the histology, it's pretty simple here. We can expect like this architecture of like the supporting cells. So you'll see that there's these like bands of like architecture throughout this entire tumor that represents the tubules that you would expect Sertoli cells to live alongside that are going to be nurturing the developing sperm. These are the important things to know about this type of tumor. It's really benign. This is a great tumor to diagnose because you know it's going to be an easy fix. There's not a lot of side effects from anything hormonal. This is a great tumor in terms of prognosis. Lastly, let's talk about primary testicular lymphoma. And this is going to be our only non-germ cell tumor that is malignant. So it's malignant, and unfortunately, it's really aggressive. Additionally, you're going to see this type of tumor in your much older males. So a vignette is going to be like a 50 or a 60-year-old male with a testicular mass perhaps some B symptoms because this is a lymphoma. This is going to be a very different presentation from the classic younger male who's in the teenage years or early 20s who's presenting with a testicular mass. And then on histology, it's also going to look starkly different from anything else we've been looking at. You'll notice here on this histology that this is all going to be white blood cells. So these like big blast-like cells, really dark purple, are starkly different from any of the other testicular pathology we saw. So if you got a histology of a testicular lesion, this is what you saw, you should be thinking about this type of tumor. It's going to be the most common testicular tumor in our older males, and the most common type is going to be diffuse large B-cell lymphoma. So in terms of our non-germ cell tumors, it's important to remember these only compose 5% of all testicular tumors. The first two that we talked about are going to be benign, and then our only malignant tumor is going to be our primary testicular lymphoma. It's going to present in an older male and have this distinct histology that is different from anything else we looked at. I hope you guys enjoyed all this content on testicular cancers. Can't wait to see you guys in the rest of male pathology. Bye.
Chị lại là bao mà
Not
mẹ
cool. Female,
về
38 female, no significant past medical history, menstrual irregularity, regular period every 28 days, but has not had a period in the last 4 months. The menstrual irregularity nila ano? So, voice sound deeper ဖြစ်လာတယ် increase body hair ဖြစ်လာတယ် tonight fever chill loss breast tenderness nausea vomiting dominant pain channel pain dominant abnormal discharge မရှိဘူး history မရှိဘူး sexually transmitted infection မရှိဘူး body sign ကောင်းတယ် no acute distress physical exam no cervical accelerating adenopathy direct ကောင်းတယ် rash မရှိဘူး regular cardiac rhythm strong heart sounds no wheeze race or from kind of appreciated
Ila
yeah
Nasa to delete severa Aswe hoa
no
Alright la mande Oh yeah man
sorry
Huh?
Shirtivas bodies ကဟိုမှာဟုတ်လား
ခုနအစတော့အီးရွေးလာတာဟိုဆရာပြောလိုက်တာစီလာတာ
စတူလစရမထုတ်တယ်ညင်
အော်ဟိုတော့ his to မေးရဆိုတော့
ဟေး
ဟို bodies များလားဆိုရောอ่ะဒါခုနဟာတယ်တူပါပဲနော်
some described capture
စေချူမှာ
crew combat ကျမမျိုးစင် Brazil ကျမနော်
ရောက်ဆက်ချူမှာမတွေ့ရ
to subpopulation, cytotrophoblast, and cytotrophoblast. Tapana Chihana. Mazachambe. We may present with oncologist complaining of weight loss, gastric pain, and cited body pressure for the past 2 weeks. She completed her last regional chemotherapy 2 months ago and has been eating a regular diet since. She denies fever, chest pain, shortness of breath, hyperchezia, anemia, giant discharge, or weakness. Most medical history is significant for gastric adenocarcinoma, GRD, hyperlipidemia, parasite, gallbladder, schizoma, hepatic, congenital failure, thyroid nut, enlarged nut, and no gluteal dominant root are initiated. Radiotherapy without normal red Kellogg's. Clear the auscultation bilaterally, then down the provision with a pedestrian right knees. Peter plus 2 plus. သူကဟောဖြစ်နေတယ်နော်ကဟတ်စီယာလေးရှိတယ်သူက12 mass လည်းရှိတယ်သူက right epigastrian right at knees ကဟတ်စီယာလေးဖြစ်နေသူက adenocarcinoma လည်းဆိုတော့ဘာတော့ထင်တယ် true grammar ကျမကြီးတော့နော် understated တဲ့မှာညာခမကျမသူက gastric adenocarcinoma နေပြောလေဟောရောက်သွားပူရီဘက်ကိုဝင်သွားတာ
weight loss
metastasis ရပါလေ
hepatic gastric adenocarcinoma
ပူရီပြန်သွား true grammar ကျပါလို့
adenocarcinoma spread to ovaries
metastasis တခုပဲ
gastric pain Anaphylactosis is typically displaced nuclear resulting in a signal ring. Show notes.
System reduces and reduce umbilicus mass polar.
Subcutaneous umbilical metastasis.
Oh, you said produce in July. I like that. Let's try to follow it. Linear gastric pathology.
Hey boot campers, welcome back to another video. This is David, your guide to gastroenterology, and today we're going to be finishing up our esophageal and gastric pathology chapter by talking about malignant gastric pathology. So let's get right into it. First up, we're going to start with gastric adenocarcinoma. Gastric adenocarcinoma is the most common type of gastric cancer, and it's most common in the lesser curvature of the stomach. Now, this should make sense because of our risk factors, specifically H. pylori, which, as we discussed in a previous video, loves to hang out around that antrum of the stomach. So H. pylori is a key risk factor. However, it should be noted that this is going to be an intestinal subtype of gastric adenocarcinoma primarily. Now, getting into the symptoms of gastric cancer, like with a lot of our cancers, we're going to have weight loss as one of the clear signs of cancer, as well as early satiety, so getting full very quickly, fatigue, and abdominal pain. Now, those are all fairly innocuous symptoms, so let me clue you on to some really high yield points that are almost certainly going to come up on your step 1 examination, especially if somebody is trying to draw you towards gastric adenocarcinoma. One of these is the lesser Trellat sign. The lesser Trellat sign is a sudden onset of seborrheic keratoses. Now, in case you haven't already seen our excellent dermatology videos, I'm going to point out to you what these seborrheic keratoses are. You can see right here, these seborrheic keratoses are these raised, waxy, almost stuck on in appearance looking plaques and or papules. And you can see them scattered throughout the back. The lesser Trellat sign is not only the appearance of these seborrheic keratoses, which can be normal in someone without gastric cancer, but a sudden onset of these seborrheic keratoses. It's going to come out of nowhere. Someone is going to go from almost none of these to all of a sudden developing quite a few of them. And that sudden onset should absolutely be cluing you in towards gastric cancer. Another big sign of gastric cancer is going to be acanthosis nigricans. Now, acanthosis nigricans can come up with a lot of different conditions, typically ones that are insulin resistant in nature. However, it is an important thing to look out for if somebody all of a sudden starts developing acanthosis nigricans, especially if they don't have signs of another disease that lead to acanthosis nigricans. And these are going to be hyperpigmented velvety plaques in the axilla and neck. So both of the things we're really looking for here, both the lesser Trellat sign as well as the acanthosis nigricans, are going to be plaques. And you can see a great example of the acanthosis nigricans right here in the axilla of this patient. Now let's hop into the different subtypes of gastric adenocarcinoma. So our first one is diffuse gastric adenocarcinoma. And this is the worst variant in terms of prognosis. This is highly metastatic, has a poor prognosis, and something called an E-cadherin mutation is very common with gastric adenocarcinoma. This is a good point to remember because examiners love to bring in mutations and genetic details when they're talking about cancers, especially when they're making you discern between different subtypes. Another thing you should know about diffuse gastric cancer is that it's associated with Kruckenberg tumor, which are bilateral ovarian metastases. This Kruckenberg tumor is going to be a great way for examiners to draw you away from the stomach and have you think about the ovaries as the primary source of the cancer. But when you see a bilateral ovarian tumor, you definitely want to be thinking about gastric adenocarcinoma. And one of the clues that they're likely going to give you is that you're going to see signet ring cells. Now, these signet ring cells are mucin-filled cells with peripheral nuclei. You can see some examples of these signet ring cells down here. And they might not say this patient has signet ring cells on biopsy, for example, on biopsy of the ovary, but they will describe this mucin-filled cell with peripheral nuclei. These right here are a key sign that you are dealing with gastric adenocarcinoma, and the examiners can give them to you not only in the context of a biopsy of the stomach, but also in the context of a biopsy off of those ovaries. Finally, one other thing you want to look for is linitis plastica. This is a thickened and leathery stomach wall, and this is something that can be seen on EGD and can also be visualized on imaging. Now, intestinal gastric adenocarcinoma is a little bit of a different beast. Intestinal gastric carcinoma can either be sporadic or environmental. Now, one of the things that we really like to think about with intestinal gastric adenocarcinoma, and you will almost certainly see come up in questions about it, are our risk factors. And those are going to be chronic gastritis as well as nitrosamines. Now, nitrosamines, they may not present as nitrosamines, but these nitrosamines may be presented to you in the context of somebody who eats a lot of smoked meats. And you may see this come up in the context of somebody who is either Japanese or who's spent a lot of time in Japan and thus has been eating a lot of Japanese foods. And these foods tend to be heavy in nitrosamines because of the method of preparation of the meats. Two other things that are really going to clue you towards this intestinal type of gastric adenocarcinoma are going to be some unique lymph nodes that are very testable. These are called the Sister Mary Joseph nodule, which is going to be umbilical, as well as the even more common Virchow's node. Now, Virchow's node is a left supraclavicular lymph node. And whenever you see a vignette where the left supraclavicular lymph node seems to be of particular interest, you should immediately start thinking about intestinal gastric adenocarcinoma, because this is a very testable point. Finally, I want to talk about one of the treatments for the intestinal subtype of gastric adenocarcinoma, especially in the context of someone with a left supraclavicular lymph node. When you see trastuzumab pop up in your answer options and you see that left supraclavicular lymph node, your mind might immediately be drawn to breast cancer. However, you should definitely be thinking about intestinal gastric adenocarcinoma, because trastuzumab is an effective treatment for HER2 positive variants of gastric adenocarcinoma. And just like how we mentioned the E-cadherin mutation with diffuse gastric adenocarcinoma, the HER2 variant of intestinal gastric adenocarcinoma is another one that you definitely want to keep in your mind. Next, let's talk about a rarer gastric cancer, mucosa-associated lymphoid tissue or MALT lymphoma. Now, MALT lymphoma H. pylori as a key risk factor for this. So anytime you think about chronic gastritis that just continues and continues, so a patient that comes in with persistent indigestion, persistent heartburn, it's really been refractory to a lot of other things. And in addition to that, they also have weight loss and other B symptoms. For example, drenching your sheets at night with sweat or running a persistently high fever. You definitely want to keep MALT lymphoma in your mind. And MALT lymphoma originates from B cells in the marginal zone. So I like to associate the B cells in the marginal zone of MALT lymphoma with our B symptoms that we're going to see with MALT lymphoma. Finally, to end the video, let's talk about gastrointestinal stromal tumors. So gastrointestinal stromal tumors are interesting for a couple of different reasons. Unlike the vast majority of our gastric cancers, gastrointestinal stromal tumors are non-epithelial in nature. They're a connective tissue tumor, so they're actually a type of sarcoma. And interestingly, they're known to arise from our pacemaker cells of the stomach, the interstitial cells of Cajal. Now, these interstitial cells of Cajal are something that examiners can really bring up as a nice tie back to anatomy. So our interstitial cells of Cajal, our pacemaker-like cells, are believed to be the origin for these gastrointestinal stromal tumors. It's worth noting that gastrointestinal stromal tumors, while the majority of them arise in the stomach, around 70% of them, they can arise anywhere in the GI tract, with the small intestine and then the esophagus being the other two most common places that you will see a gastrointestinal stromal tumor. As I mentioned, they are a form of sarcoma. And a final thing to keep in mind about gastrointestinal stromal tumors is that you're going to have c-KIT mutations. These are extremely common with gastrointestinal stromal tumors, to the point where if you're confused about which type of cancer this might be, and you see c-KIT mutation come up in your answer options, you immediately want to read back through that vignette while keeping gastrointestinal stromal tumors in mind. Now, gastrointestinal stromal tumors don't present in a very loud way. They could present with trouble swallowing, gastrointestinal bleeding, indigestion, things like that. And the only other detail you should really know about gastrointestinal stromal tumors for the purpose of your step 1 examination is that when they do metastasize, they metastasize typically to the liver. That's been it for this video. I hope you all enjoyed this chapter, and I'll see you in the next one.
See you. Bye.
Ako sa sila yun.
Just a female, previously healthy, bone and national weight loss, fatigue, anxiety, non-pain for the last month, drinks 2 beer each weekend, has 10 packs years, cigarette smoking history. Bishop managed to get a big restaurant, diagnosis Australia, smoked meats and fried foods.
Not very high.
Gastric cancer risk ပေါ့နော် smoking လည်းရှိတယ် alcohol လည်းတောက်တယ်သူက smoke mix ဆိုတဲ့စာနေဆို acute mammogram via colonoscopy installation acute ဖြစ်တယ် denial fever chest chest pain shortness of breath နဲ့ဆိုတော့တယ်သူ cheese ရမလိမ့်တာ neurovirus sign ကောင်းတယ် active fatigue on physical examination Functional anemia, auscultation, regular cardio rhythm without normal red scale of TL and bilaterally. over the epigastrian tenderness shear, fullness over the suprapubic region, no spike at discharge edema, bilateral muscle, be shaded over the administrative palmar exam. With a static jumal, true gamma jumal to pure in no. Character of the gastric and sound piano pure. Weight loss, anxiety, abdominal pain, GI malignancy, gastric diet constraint, small breaks, gastric carcinoma, nitrosamine powder, and no risk for the developing gastric cancer, through tumor associated with metastatic gastric adenocarcinoma. Diffuse type gastric carcinoma spread to the ovary. Most commonly bilateral at the time of diagnosis, distinguishing them from primary ovarian tumors. Epithelial tumor. C125 positive, not epithelial tumor. Follicular septica lutein set. Coming down ovarian set. Usually unilateral. Graphia follicle rupture. Graphia follicle vanity. Oocytes do not typically present formal abdominal stem ascendants. Diffuse type gastric cancer transfer the starts just like to the ovary. Or third Havainia. Teratomoida, but you are teratomoida. So 48-year-old female. Hyperlipidemia, chronic position with a history of decreased appetite, fatigue, abdominal pain. Recently, uploads have lost despite experiencing low abdominal weight gain. Weight or jaw, July Masachila. Sexually active with her husband and trying to buy place 2 years ago tonight. He was just pension as a year. I don't know China bleeding them shoe. For this side, corner, oxygen situation corner, toxic female, no acute distress. She has a epigastric tenderness deprivation without cutting or rebound. Several lesions sheet or a bilateral. And when your pelvic is a bilateral aneurysm or the aneurysm boundary wall. Signal remote, no.
USMLE.
Develop. Plus, severe keratosis is a trillet sign.
Achieve decrease appetite, weight loss, fatigue, abdominal pain,
We lost fatigue, abdominal pain. bilateral aneurysm, ovarian malignancy.
Sorry. The fifth gastric carcinoma. Bilateral.
Multiple several keratosis. Trichombetulas. Không hiểu là lại. Acanthosis nigra. Not just a dead female plasma show endometriosis present to EDOLI. Bloating, constipation, abdominal pain. Unable to have a bowel movement for the past 5 days, or fever, chest pain, could be dose fatigue, 10-pound loss over the past month, 10-pound loss per day. For the sign, the Dutch beer female conjunctival pale anemia shade, regular cardiac rhythm without normal red gallop, and clear bilaterally, abdominal fullness and tenderness to publication over the left lower quadrant. Left lower quadrant side, period, +2, bilaterally, no rush-bitten tumor, ultrasound 47 heterogeneous obesity. Cystic or solid option, weight loss လည်းဖြစ်တဲ့ဆိုရင်တော့ဘာလို့ထင်လဲmucinous လို့ထင်တယ်ညီ
Adenocarcinoma လားဟုတ်လား Business လားအော်ခုနကဟိုပါပဲ
adenocarcinoma ပဲ serious တာမျိုးဆိုငါသိမသိကြဘူးရှိ
Epithelial ovarian cancer
အော် serious က most common ဖြစ်သွားတယ်နော် Cystic type, colloid type, transdermal serious with small body, popular rejection, small cytoplasm. Serious most common form, epithelial, television about
perform cyst and solid ultrasound. Serial stereocarcinoma is characterized by venous anomaly, shower stroma invasion, along with multiple blood formation to show a slight degree of thick, shaggy lining. The central laminator calcifies stretches some body, find specific stresses due. So, customer is with China cancer, China adenosis galactica. Yes, adenocarcinoma purely, China cancer anyway. Whereas when you look at proliferation of glandular in to top of China, there's also clear settled histology. Okay. Similar necessity to carcinoma very large, but it's still appendix garden, other GI cancer large. Okay. That's similar seriously in the rare. Papillary ovarian cancer most common pregnancy, more serious stenosis is the muscular sector. Stolima, papillary ovarian cancer, the display biliary ablation, cell invasion to the stroma. Multiple papillary formation cellular ATPR. Serious stenosis most common. Okay.
All right, guys, let's get busy talking about ovarian cancer. In this video, we're going to be talking about the overarching themes of ovarian cancer, and then we're going to break down into tables to get the nitty-gritty details that you need to know for test day that correspond to the various types of ovarian cancers. So let's start out by talking about the pathophysiology, which is going to be neoplastic transformation of ovarian tissue. Now, we have different types of ovarian tissue, which are going to transform, and we'll talk about that a little bit later. But I wanted to start out by talking about some of the etiologies or the risk factors of our ovarian cancers. So it's going to be the most common adnexal mass in our females greater than 55. So this is going to be a diagnosis you're usually expecting in someone who's a postmenopausal female. It's not always going to be that way, but that's what I want you guys to be compartmentalizing ovarian cancer as. Additionally, I want you guys to look out for some historical risk factors. And these historical risk factors are almost all going to be related to increased estrogen exposure. We know that the ovarian tissues are sensitive to hormones, and estrogen exposure is actually going to lead to an increased risk of cancer. So we know that with increased age, you've just been around on this earth long enough to get more estrogen exposure. So that is going to be a risk factor. In terms of PCOS, we know that there is failure of follicles to rupture, and this leads to increased levels of estrogen in our patients with PCOS. So this is a risk factor for ovarian cancer as well. You can also imagine that you had a lot of cysts in your ovary. This is going to cause a lot of irritation, and we know that irritation can lead to transformation in tissue. So this is another reason why PCOS is a risk factor. In terms of endometriosis, we know that endometriosis is uterine tissue that has migrated out of the endometrium, and it can get stuck on the ovaries, and it can form these things called chocolate cysts. They can be really irritative, and also they're going to be sensitive to changes in hormones as well. So it's kind of getting this double whammy. We're getting estrogen that's going to cause this uterine tissue to grow, and it's going to irritate the ovary more, and it's going to lead to an increased risk of cancer. And then finally, infertility. We know that pregnancy is protective against a lot of our female cancers because it is a period when we are not being exposed to quite as much estrogen, because we know that progesterone is going to dominate the period of pregnancy. And so pregnancy you can think of as a protective factor against ovarian cancer. Now let's move on to some other risk factors. These are going to be more molecular genetics type risk factors. So we have our BRCA1 or 2 mutations. We know that BRCA is a tumor suppressor gene. Specifically, it is a caretaker gene. So it is going to help repair DNA in cells that have undergone DNA damage. And this is going to be protective against ovarian cancer. We have Lynch syndrome, which is going to be a risk factor. And Lynch syndrome is a collective group of cancers that affect people, and Lynch syndrome is going to be inherited. So if you know you have a family history of Lynch syndrome with things like colon cancer and ovarian cancer, that would be something in a vignette that might lead you to an increased risk factor for ovarian cancer. And finally, we have CA125, which stands for cancer antigen 125. And this is a really useful protein marker for sensing how well an ovarian tumor is responding to therapy. So if ovarian tumors are responding well, this level will go down. However, if they are not responding well, this level will go up. So it's useful as a prognostic factor, and it's less useful as a diagnostic factor. That's something they like to ask about on test day. Lastly, let's talk about some protective factors. These are going to be multiparity, breastfeeding, OCPs, as well as tubal ligation. And you can think of these as all things that are preventing ovulation, right? So if we prevent ovulation, we're not getting those follicles rupturing out of the ovary every month. And those tiny ruptures in the ovary every month are going to lead you to an increase of ovarian cancer. And so if we can reduce those things by making sure that a woman is like not ovulating, that is going to help be protective from ovarian cancer. Now let's move on to talk about the different types of ovarian cancer that we're going to cover in more detail in our tables. I just want to give an overview. So starting with epithelial tumors, these are going to be the ovarian surface epithelium that turns into cancer. So specifically, that's going to be this area that I'm highlighting here, right along the surface of our ovary. And these are going to be serous or mucinous producing. So I like to think of these as like fluid producing tumors, and they're going to be on that external epithelia. That ovarian coating is what that's going to be. And it's going to usually be benign because these are just going to be surface epithelial tumors, and they tend to be relatively benign. They don't go crazy. They just produce a lot of cystic fluid, a lot of mucinous fluid, as opposed to, let's talk about our germ cell tumors, which are going to be coming from our primordial germ cells. So our primordial germ cells in this diagram, which I'm going to highlight in gray here, are these little eggs. And so the little eggs are what are actually going to turn into cancer. And we know that these are really multipotent cells. So they have the ability to transform into a variety of things because they are largely undifferentiated. So we can get things like yolk sac tumors, which are going to be made of extra embryonic tissue, teratomas, which are going to be made of somatic tissues, and then dysgerminomas, which are going to be made of undifferentiated cells. They're completely plastic. They can pretty much turn into anything at this point. And so it's important to know that these types of cells are going to be more likely to be benign or malignant, depending on what they turn into. And then finally, we have our sex cord tumors, which are going to be made largely of follicle or stroma. And when I refer to follicle or stroma, I refer to the part that is surrounding the egg. So these would be the granulosa cells that support the developing follicle. And then stroma is going to be the part of the ovary here that is supportive and also making some hormones. So this can be Sertoli or granulosa cells. And the stromal variants, which are going to be the portions here inside the stroma, are going to be composed of fibroblasts or primitive gonadal stroma, whereas the ones that are in the follicle are going to be mainly granulosa cells, Sertoli cells, theca lutein cells, things like that. And then these can be benign or malignant as well. And then I just want to wrap up with the incidence with our endometrial, then ovarian, and then cervical in the order of most common cancers affecting our female patients. So stay tuned for our tables, and we'll get into more detail on each of these cancer types.
now. Infertility.